Okay, now let's get started further. So after the biopsy, we have the next section, excision. We have a two type of excision in our manual. Let me bring that up first. Skin tag. Here we go, excision. So we have two type of excision in our manual, excision of benign lesion and excision of malignant lesion. We have to code benign lesion when the lesions are benign in nature, and we will get the documentation which state that neoplasm has been removed, inflammatory lesion has been removed, cystic lesion has been removed. Whenever we have these type of documentation, it will represent that benign lesion has been removed from the patient's body. Also, when we are going to code the benign lesion excision, we have to make sure that we are not going to repair in conjunction with the benign lesion. You have to make a note which will says that whenever you are going to code the excision, with excision you are not going to code the repair of the same site, because simple repair is always included in the excision. Excision means removing of the lesion. Whenever doctor is trying to remove the lesion, doctor will definitely remove the doctor will definitely repair that area after the removal. So repair is always included in the excision, and you are not going to build that separately in conjunction with the excision for the same location. If the doctor is doing the excision at the different location and the repair is at the different location, we are going to build both with the modifier 59 to represent that both has been happen on the different location. Now let's move further. Our excision codes are based on the diameter. Diameter means that how much excision has been completed, that how much area has been excised. Whenever you're going to consider the diameter or you are going to calculate the diameter, you have to make sure that in the diameter you have to include the lesion, length of the lesion. So length of the lesion, as well as you have to add the margins of the both sides. So whenever you're going to code the excision, you have to code the excision as well as the margins of the excision. So the first one is 0.5 centimeter or less, and this is based on the anatomical group. Anatomical group means for if the excision is happened on the trunk, arm, or legs, we are going to pick a code from the 11400 to 403. If it is at scalp, neck, hand, and feet, we have to pick a code from this series. So whenever we are going to code the excision, we have to make sure that repair our excision code is based on the type of lesion. We have two type of lesions, benign and the malignant. To determine whether the lesion is benign or malignant, you have to refer the beginning of the series where you will get the terms which will represent whether it's a malignant or whether it's a benign. Like you can see here in the malignant, we have these terms here. So it will be malignant excisions. After identifying the type of lesion, you have to identify the length of the lesion, and you will add the margins. You will add the margins to accurately code the excision. So the formula is length of lesion plus margins of each side, and then with the excision you will not code the simple repair. Simple repair is always included for the same location. Any doubts? Any doubts? Any questions? Okay, I'm going to send one question. for the lesions excision, then we will proceed further. I have shared one question. Try to solve that. Here the patient is coming for the excision of the malignant lesion. It's 3:13. We will discuss this question at 3:15. It's 3:15. I haven't received any answers yet. Ashnavi, Zamil, Lokesh, Shepali. We just have a few candidates here, right? We can make this class a more interactive so that you can understand what's going to happen and what's happening here. So where you guys take, did you need a little bit more time? Jamil, where you are stuck? Vaishnavi, are you able to understand the concept or should I repeat? It is it is completely okay if you want me to repeat. We can repeat and we can discuss this question together. Okay. I think you guys are not interested, so I'm skipping this question. I'm not. Oh, I got the answer. Sure. Vaishnavi, you can unmute yourself. You all have the access to unmute yourself. So I'm going to repeat it one more time and we will discuss this question together also. Just give me a second. Let me copy this question. Oh, you guys are unable to unmute yourself. Just give me a second. Let me see how to change the settings. Just a second. Huh? Can you try now? Are you guys unable to unmute yourself now?
Yes, ma'am. Yes, ma'am.
Perfect. So let's discuss this topic one more time. So we have discussed about the excision. Just a second, I don't know how to close this one. Okay. So we have excision topic. So whenever we have to build the excision of the lesions, so lesions are the locations or the neoplasm or the any area where the cells has been growth abnormally. So whenever we have a high number of growth cells at a particular location or the group of mass, at that time we are going to call it as a lesion. So whenever we have to build the excision of lesion, we have to make sure that first we have to determine the type of lesion. Our first step is to determine the type of lesion. Once you have determined the type of lesion, we have mainly two type of lesions, malignant and benign. And to understand whether it's a malignant or benign, you have to see the type of lesion. Like you can see here, this is a basal cell carcinoma. So basal cell carcinoma is a malignant lesion. How we have identified, you can see here. Under the malignant, we have basal cell carcinoma. So basal cell carcinoma is a malignant lesion. So we have two type of lesions, malignant and benign. And your first step is to determine the type of lesion only. So here you have identified it's a malignant. Once you identified the type of lesion, then you have to determine the length of the lesion because our all excision code are based on the diameter. Our all codes are based on the diameter as well as anatomical classification. This is the anatomical classification. So once you determine the anatomical classification and the lesion diameter, so to calculate the actual excision diameter, you have to calculate the lesion diameter. Then you have to add the margins. So like you can see here, our lesion is 0.6 centimeter, oh sorry, 0.9 centimeter lesion patient have, and there is a zero point 0.3 each side margins. So 0.3 and then 0.3, the 3 plus 3. So the total will be 1.5. So you are going to build 1.5 centimeter excision instead of the 0.9 centimeter excision. Clear to everyone? First step, type of lesion, and the second step is you have to identify the exact excision diameter. And your excision diameter is length of the lesion plus length of the margins. As well as whenever you are going to build the excision, your simple closure is always included in the lesion excision, and we are not going to build that separately. So excision is defined as a full thickness removal of a lesion, which includes the margin. It will include it in the excision diameter, and it includes the simple closure. If the doctor is doing the intermediate repair or the complex closure with the excision, we are going to build that separately. But if the doctor is just doing the simple repair, then we should not build that simple repair in conjunction with the excision. Does that make sense? Is it clear to everyone now?
Yes, ma'am.
Okay. Now try to attempt this question. You have this question here. Try to attempt that. Very good. I received this one from Vaishnavi. Rest. Anshini, Zamil, Kashish, Lokesh, Shefali. What's your responses? Are you guys able to understand or not? Okay. Now let's do it together. Zamil, did you need little bit time, or shall we proceed and attempt this question together?
I'm doing it.
Okay. Let's wait for 1 or 2 minutes more. Okay, now let's do it. So now in our question, we have basal cell carcinoma on the left chain. Doctor did 3 centimeter excision here and 0.3 centimeter margins removal and total 4 centimeter closure. The patient left chain one examined, excision done, blade scalpel was then induced, and the complete incision was carried out. That's it. So first we have identified it's a malignant lesion. It's a malignant lesion. Then Our second step is we have to calculate the length. So the length is 3 plus zero point 0.3 centimeter plus zero point 0.3 centimeter, because we have to add to the both sides. So we have to add at the both sides. This one and this one, remember, we have to add at the both ends. We cannot use only one margin. If we are taking 0.2 margin here, we have to calculate it at here also. Then, so the total will be 3.6 centimeters square. Now, after the incision, doctor close the wound in layers. So here we have the documentation. The simple, that is non-layered, that will be included, but the layered closure is not included. So whenever there is a more than one layer that has been repaired, that will not be included. We are going to code it separately. So whenever there is an excision of benign lesions, that code begins from 114 series. You can see here, this is the excision of benign lesion. Our code starts from 114. And whenever there is excision of malignant lesion, we have a code from series 116. So we have to rule out this one, we have to rule out this one. We are left with option A and the option B only. So the difference between option A and B is code 12013 and 12052. Now let's see the difference between these two codes. So we have to pull these two codes here, 12052 and 12013. So the white 2 is a repair of intermediate wounds. Intermediate wounds are layers. When the wound has been closed in the layers, more than one layer has been closed, then we are going to call it as an intermediate. And the next option is 12013. 12013 is a simple one. Simple repair means when a single layer has been closed, that is simple. In our question, wound has been closed in layers. So we are going to consider the option A. So answer would be A. Are you guys clear that how I have reached to the option A?
Yes, ma'am.
Jamil, are you clear on this point? That why the option should be A, answer should be A.
Yes, ma'am.
Okay. Now let's move further. So this is the excision going on. Let's move further. So after the excision, we have the debridement here. Debridement of nails. We have all codes related to the nails here. When the doctor is doing the debridement of the nails, our code should be 11720 for 1 to 5 nails and 11721 for 6 or more. So if the debridement has been completed on 3 nails, we are going to consider the code 11720. If it is more than 6, then we are going to code 11721. Now I have a question for you. Let's say doctor did the debridement to the 8 nails. So what will be the code for 8 nails debridement? Do we have to use the separate units?
Yes, ma'am. Separate, ma'am.
Separate units. How many units should be?
Uh, Two codes should be there, ma'am. 11720 and 11721.
Okay, Vaishnavi, what do you think? How many codes we have to use
We should
for
use
the
only
degree?
one, ma'am.
We should use only one. And what will be that code, Vaishnavi?
11721.
11721. That's correct. Zamil, we need to use only one code here, that is 11721. Why? Because our 11721 says six or more. That means if the lesion debridement has been completed on any number of lesions which is more than six, we are going to use 11721 only. Clear, Zamil?
Yes, ma'am.
Okay. Now let's move further. 11730. Okay. Next is avulsion. Avulsion means ठीक है 11730 avulsion means removing the nail completely. Whenever doctor is removing the nail completely, that means avulsion. So avulsion of nail plate, partial or complete. So whenever doctor is removing a nail plate for a single lesion, 11730. For each additional nail plate, we are going to use 11732. So if it is a single lesion, single nail, we are going to use 30. If it is more than one nail plate, we are going to use 11732. So now I have a question. If two, not two, let's say if three nail plate has been removed, avulsed. So how many codes we have to use for three nail plates?
Two codes, ma'am.
So, ma'am.
I accidentally left the meeting. Does anyone of you answer? If there is a version of three nail plates, how many codes we
Two
have to
co
do?
Two codes, ma'am.
And what will be the codes? 11730 and what?
11732.
11732. Do we have you need to use any additional unit for 11732 or not? Okay, Jamil, tell me how you have identified that we have to use only one unit of 11732.
Ma'am, for a single nail plate, we'll use 11732. And for others two, we'll use 11732 into 2. So it will be three
Yes,
nail plate total.
exactly. So it should be unit 2. So to represent the version of three nail plates, we are going to use 11730 and 11732 into 2. Our first nail plate covers from here and additional nail plates. For the additional nail plate, we are going to use the additional 2 units. Next, we have evacuation. If the patient is coming for the evacuation of sublingual hematoma means if there is any collection of blood at the bottom of the nail, that is sublingual hematoma. Let me show you the image of sublingual hematoma. So if the patient is coming for the evacuation of hematoma, we are going to use that code. This is a subungual hematoma. So if the patient is coming for the evacuation of subungual hematoma, we are going to use 11740. For the excision of nail and nail matrix, we are going to use 11750. In the avulsion, nail plate has been removed. In the excision, there is excision of nail and nail matrix. Then we are going to consider it as a 11750. Then we have 11755 for the biopsy of nail unit. Then we have 11760 repair of nail bed. These codes are word to word, so I'm not going through with the all codes. Let's proceed with the other guidelines. So after the nail, we have a section pylondiasis. We are going to use a code for the pylondiasis from the series of pylondiasis, where the excision of pylondiasis, whenever doctor patient is coming for the excision of pylondiasis. We have three different type of excisions. Simple, when cyst has been removed with the same single excision, then we are going to consider 11700. We are going to quote extensive or consider extensive if there is a drain placement in conjunction with the excision, and complicated when more than one incision has been required as well as drain has been placed, then we are going to consider it as a complicated. Okay. Now next section we have introduction. In the introduction section, introduction means when something has been inserted or the removed from the body, we are going to pick a code from the introduction section only. So our first is injection intralesional up to 7 lesions. If it is more than 7 lesions, we are going to use 11901. 920, that doing intradermal introduction. So whenever doctor is inserting insoluble opaque pigment so that color defect has been corrected, then we are going to use 11920. This code is based on the surface area. If it is 0.6 square centimeter or less, we are going to use 11920. If it is more than 6 square centimeter till 20 square centimeter, we are going to use 11921. If it is each additional, then we are going to use 11922. Then we have subcutaneous injection of fine material, that is collagen. So whenever doctor is inserting the collagen material, we are going to use 11950 and 951. That is based on the volume of the material, that how much material has been inserted. Next we have 11960, insertion of tissue expander other than breast. So if the tissue expander has been inserted, if it is inserted in the breast, we are going to pick a code from series 19. If it is in breast, we have to use 19357. If it is other than breast, we are going to use 11960. If there is a replacement of tissue expander, this is a silicone tissue expander with a permanent implant, we are going to use 11970. If it's just in removal, then we have subcutaneous hormone pellet implantation and then insertion of drug delivery implant. This is also known as subdermal contraceptives. So whenever patient is coming for a subdermal contraceptives, we can use this code. And for the removal of implantable contraceptive capsule, we have to use 11976. 982 is removal of 9 biodegradable drug implant. and 11983 is removal and reinsertion of the drug implant device. Next topic is an important topic, repair. Repair means closure. So whenever there is an laceration means cut in the body, and doctor need to repair that wound. In that case, sorry, I missed where we were talking about. So I was talking about the repair. For the repair, whenever there is a cut and doctor is doing the repair or adding the suturings or doing the suturing of that area, then we are going to use a code from the repair section. We have three type of repairs: simple, intermediate, and the complex. So the first is simple repair. We have to use simple repair when only the superficial layer has been closed, or if whenever only one layer has been closed. So if there is a one layer closure, we are going to consider it as a simple. If it is more than one layer, that is layered closure, or deeper layers has been closed, we are going to consider it as an intermediate repair. For the complex repair, if in conjunction with the layer closure doctor is doing the debridement, then we are going to consider it as a complex closure. So the difference between the simple layer, intermediate, and the complex is just when if there is a single layer closure without debridement, without undermining, we are going to consider it as a simple. If it is in more than one layer, a deeper layer has been closed, then we are going to consider it as an intermediate repair. For complex, intermediate we can consider even at the one layer. If one layer has been closed but that requires the cleaning, then also we are going to consider it as an intermediate. We have this documentation here. So even if single layer has been closed, but that is heavily contaminated, that require extensive cleaning, so in that case also we are going to consider it as an intermediate only. After this we have a complex repair. So complex repair also repair of wounds that requires the debridement, heavily cleaning, and extensive undermining. Extensive undermining means that we have to explore that area and clean that area completely. That is extensive undermining. So our all codes for repair are based on the anatomical location as well as size, and we are going to add the size. Let's say patient had a simple repair on the scalp as well as neck. On the scalp there is a 3 centimeter and on the neck 2 centimeter. So total we are going to bill 5 centimeter. Why? Because the both anatomical location belongs from the same anatomical classification. If two locations belongs from the same anatomical locations, we are going to add the size then, and if same classification as well as same type of repair has been performed. If the same type of repair has been performed, then we are going to add. If it isn't different, let's say On the scalp, simple repair has been completed, and on the neck, intermediate repair has been done. So for neck here we have. So if intermediate repair has been done on neck and the simple repair has been completed on the scalp, then we are not going to add. Why? Because the different type of layer closure has been performed on both the sides. If the different type of layer closure has been performed on both the sides, in that case, we are going to code it separately. If same type of layer closure has been done, simple at both areas or intermediate at both areas or complex at both areas, then we are going to add these centimeters or the areas for same classifications. Does that make sense? I know this topic is little bit difficult. Okay, let's do one
Mom,
thing. Yes, Vaishnavi.
I have one doubt. So if simple repair has been done on neck and on scalp, then we need to add it, right?
If simple repair has been done on neck and the simple repair on the other anatomical location which comes under the same anatomical classification, then we are going to add. But if the type of repair are different, then we are not going to add.
Okay,
Okay,
thank you.
let's try to attempt one question. We will do one this question, then we will proceed further. What's try to solve this question. I haven't received any answers yet. Did you need some more time or shall we discuss?
Ma'am, it would be option B, ma'am.
Option B. Vaishnavi, what's your thoughts?
Ma'am, I need some time.
Okay, take a moment.
Done, ma'am.
Okay, I have just received the two Any other answers? Okay, now let's do this together. Let me copy this question and paste on my screen. Okay, so in our question, patient have the laceration, 3 centimeter dermis laceration on scalp. So let me mention it here. So scalp, 3 centimeter, dermis with 2.5 centimeters on the face. 0.5, 2.5. So it will be total 1 centimeter on face. So face 1 centimeter, 5 centimeter on right leg, right arm 5 centimeter, right leg 5 centimeter. So 5 centimeter on arm and 5 centimeter on leg. The physician stapled the laceration on scalp. So on the scalp, doctor did the staples. Physician used these adhesive strips for the face. So for face, only the adhesive strips were used. Whenever a laceration or the cut has been closed with just using the adhesive strips, then we are not going to build that separately. So if the closure has been closed with just using the adhesive strips, then it will be included in the E&M and we are not going to build that separately. So that will be, we are not going to build for the face because it is in adhesive strips. Next we have legs and arms were closed, heavily irrigated, and then embedded tub is performed on both wards, and then single layer has been closed. That means they both has been closed with the intermediate approach. Intermediate approach. So intermediate closure has been done on the right arm
Ma'am,
and the right leg.
why is intermediate, ma'am?
Because it's in
Because
single
here,
layer
ma'am,
and doctor is doing the heavily irrigation. So we have a term here, we just studied that if the single layer closure has been done on the heavily contaminated wounds, then we are going to consider it as an intermediate. Zamil, clear? Jamil, is it clear to you now?
Ma'am, here, okay, ma'am, okay.
You didn't got. Okay. So if it is a single layer closure, we are going to consider it as a simple. And if in conjunction with the single layer closure, wound has been extensive cleaned, then also we are going to consider it as an intermediate. Clear?
Okay, ma'am.
So I'm going to neglect the option number C because in the option number C we have the wound debridement here. So we are going to rule out this. Now we are left with option A, B, and D. In the option B and A also, we can see we have a code 12011. 12011 is for the simple repair. So on the scalp, simple repair has been completed because it has been closed with just a staple, and this is an dermis laceration only. So what we are going to do, we have to rule out the option number A also because we cannot use same code two times. So option number A has been ruled out. As well as we have to rule out the option number B also because we cannot use same code two times for this series. We can use for other series but not for this series. Why? Because here we have to add the size. So we are not going to use the same code twice. So the correct answer should be D only. And we have identified with this with just by ruling out. Jamil, Vaishnavi, and everyone clear that why the answer should be D only.
Yes, ma'am.
Yes, ma'am.
Ma'am, why can't we add that?
Why we can't use for two codes for same unit? This is what you want to ask?
Yes, ma'am. Yes.
Because look, 12002 is for 2.6 to 7.5. But we have discussed that we have to add the size, right? We have to add the size. Like you can see here, 201 for 2.5 centimeter or less, 202 is 2.6 to 7.5, 204 to 7.6 to 12.5. So these codes are based on the length, total length, instead of the total, like how many repair has been done. So if there are two repairs of the same classification, same type, then we have to add the size instead of billing that twice. Does that make sense, Jamil?
No, ma'am, I didn't get, ma'am.
Okay, let me do one thing. We have these instruction here. Just read these 2 points. Read these 2 points. I'm going to mute myself. Just read these 2 points. Please let me know whenever you are ready with the reading.
Yeah, ma'am, done.
Samil, can you explain what you have understand with these two? Okay, it simply says that repaired wound should be measured and recorded in the centimeter. So we have to record that into the centimeter. And if multiple wounds are repaired, we have to add them together if it is in the same classification or same anatomical locations. Like this is the same classification. Scalp, neck, axilla, these are the same anatomical classification. So if there is a multiple wounds, we have to add them. Okay.
Yes, ma'am.
We should
Ma'am,
not add the length. Yes.
if suppose there is a repair of scalp and there is also repair of lower extremities, then should we add that or not?
No. Lower extremity. Yes. If it is a simple repair of the scalp and the extremities, as they both locations comes under the same anatomical classification, we are going to add it.
But ma'am, it the note says do not add the lanes of repairs from different grouping of anatomical sites.
Yes, different grouping. Let's say if there is a simple repair of scalp as well as there is a simple repair of face, then you are not going to add it because these two are from the different grouping of anatomical location. We have a different codes based on the grouping, anatomical grouping. Like in this code, this is also for simple one, but here we have the location face, ear, eyelids, nose, lips, and this. So if it is in different grouping, like one from face and another one is from the scalp, then we are not going to add it.
Okay, ma'am, got it.
Zamil, are you able to understand?
Yes, ma'am. Okay, ma'am.
Okay. Let me see if I can find any other question for your practice. I'm not able to identify any other question as of now. I will send few questions for the practice later on. Uh-huh. Okay, not able to identify the questions for you. So we'll move further. Just remember one thing. If the tissue has been closed with just using the adhesive strips, we are not going to coat that separately. Okay. Now let's move further. Okay, I have one question. I'm going to send that question to you. Try to attempt that question. Answer from the. Okay, now let's do it together. So patient is involved in the motor vehicle accident. 8.6 centimeter on head, 5.5 on cheek, 4 centimeter on left cheek, and 4 centimeter chin, 12.5 on chest, and laceration chin. The wound on her chin required layered closure. Rest all are the complex closure. So the chin one is an intermediate, and 12.5. The rest all is complex. So we have to use 12052 anyways for the intermediate, and for rest of them we have to add the size. Now let me add the size. We have to rule out the option number B because we cannot use same code twice. We have to option rule out the option number B only, and let's see any one option we can rule out. 3, 2, and 3, 3. No, anyone I except B, we cannot rule out any other. Now let's pull these codes in the book. 3, 2, and 3, 1. So 1, 3, 1, 3, 1, 3, 2. 3, 1 includes forehead, cheek, chin, mouth, neck, and so on. So patient had the laceration on forehead and cheek. So 8.6, 5.5, and 4. If we add these two, 3, because we have the forehead here and cheek here. We does not have the chest here. So we are going to add the forehead and the cheek only. So if we are going to add this, So that will be 18.1. So to build the 18.1, we are going to use 13132 for 7.5 centimeter, and then 131. So for each additional 5. 7.5 plus 5, that will be 12.5. And then for additional 5, we are going to use one more unit. So there will be 2 units. And then for 5.5, we are going to use 3. So we have to use 3 units of 133. We have to rule out this option also. 31, 31. We cannot use the lowest one. So D is ruled out. Then we have here 4 units. We cannot use 4 units also. Then we have 13101 and 02. So answer should be C. So answer is C. Let's see. So Zamil, you are correct. Vaishnavi, did you get that why the answer should be C instead of the A?
Yes, ma'am.
Okay. So I hope repair is clear to everyone now. Now let's move to the ATT. ATT is the next main topic. So whenever you are going to build the ATT, with ATT you are not going to build the excision. ATT means adjacent tissue transfer. That is also known as Z plasty, W plasty, and VY plasty. So if it is in Z plasty, W plasty, or VY plasty, we are going to consider it as an ATT. Sorry, I was speaking in mute. So whenever patient is coming with the ATT, with ATT, excision is always included, and we are not going to build the excision separately with the ATT. So ATT includes excision. The excision of the same site as well as the ATT is not separately reportable. We have to build the ATT only if the doctor did the excision and the Z plastic. So ATT codes are based on the anatomical location as well as the size. So anatomical location as well as the size. If the different locations ATT has been performed on the different location, we are going to build that separately. I'm just going to mute myself. Take a moment and just go through with this paragraph, please. Just go through with this paragraph. Done with the reading?
Yes.
So for today, I'm wrapping it right now. I'm not going to pursue further because I'm not well today. So we will start from the skin replacement surgery from the next session. So for today, let's wrap up the session a little earlier. Any questions so far?
No, ma'am.
No, ma'am.
Okay. Okay. Now let's wrap up this session. Thanks everyone. Thanks for your time.
Thank you so much, ma'am.